Hello everybody, I welcome you to my presentation. Today the topic of my presentation is WSH approach towards stroke rehabilitation and prevention, and this topic has been certified by the Board of Certification of London Academy of Sports and Health Science UK. I'm a resource person. My name is Dr. Syed Mohammad Waris. I have done my bachelor's in physiotherapy from India, master's from US, and MD in alternative medicine. And I have been working previously worked with the National Stroke Association of Malaysia, and I was heading the division of Sabah. And I'm working as Associate Director for London Academy of Sports and Health Science UK. And these are my details and my email and my mobile numbers. You can reach me out there. First, when I start, you please relax and listen it carefully, because I'm going to talk about stroke, and stroke needs relaxation. Now, stroke, as you know, is cerebral accident or acute focal cerebral deficit resulting from vascular disease lasting more than 24 hours. Stroke is sometimes called as brain attack. There are different types of stroke. Ischemic stroke, the reduction in blood flow results in an ischemic stroke, and most strokes are ischemic. Then we talk about causes of ischemic stroke. Ischemic stroke can be due to thrombus, due to any vegetation, arterial, calcific debris, myocardial infarction, carotid or vertebral, and can be arterial source, arthoma, or dissection. And another very dangerous is hemorrhagic stroke. Another common cause of stroke is a leaking vessel in the brain. This is a hemorrhagic stroke. Then intracranial hemorrhage. Intracerebral hemorrhage occurs when a diseased blood vessel within the brain bursts and blood flow leaks inside the brain and causes the pressure, and thus the stroke happens. And very, very dangerous is subarachnoid hemorrhage. Occurs when a blood vessel just outside the brain ruptures and the blood pools out over there. And mostly nowadays, which is widely debatable topic and also very important, is pediatric stroke. Pediatric stroke occurs in most of the children between the age of 3 and 10, and it is due to the skill cell disease seen in the children. And transient ischemic attack, which is known as mini stroke. It's a kind of a warning of stroke, and when this happens, there is no symptom, there is no permanent damage, but symptoms last within 24 hours. The person comes to the normal, and this is not a permanent damage, but this is a warning stroke that in future stroke may happen. So you have to be very cautious about it. And now coming to the signs and symptoms of the stroke: certain numbness or weakness of the face, arm or leg, especially on one side of the body. And nowadays, when you are seeing a person who is feeling unconscious or like that, you have to act very fast. Check out the face of the person, check out his arm, check out his speech. The face may be drooped. Check out his arm, whether the arm is having any resistance or it is a flaccid, having no power. Speech, check out his speech, ask him some questions. Check out his speech, whether he can speak or there is a slurredness in the speech. And if you have time, call emergency number and call the ambulance very quickly to shift him to the hospital. And the risk factors, previous slide please. Another signs and symptoms include some questions, mini questions you have to ask him, like if a person is unconscious or he's suffering, he's having trouble in seeing in one or both of the eyes, having trouble walking, DTC or lose balance, has certain severe headache which he does not know where from the headache is coming. And person feels confused of the state where he is existing. Like there are certain symptoms like that. Risk factors of stroke are family history, age and gender, race, and it's seen in higher in the African Americans even at younger ages. Previous heart attack or stroke, it can be second time stroke as well. High blood pressure, cigarette smoking, high cholesterol, diabetes, carotid artery disease, and obesity. And you know, nowadays the rate of obesity is more in the world, and that's why there are high chances of stroke. And you will see stroke is becoming very, very common disease within the community. And physical therapists can help you reduce your risk for stroke by changing your modification in your lifestyle. Clinical features of stroke include stroke can cause a range of long-term problems if no rehabilitation is given in the beginning. Muscles will initially be flaccid followed by spasticity. If proper rehab is not provided, it will advance to contracture and contracture to deformity, and thus the handicap. Inability to move on one side of the body, which is known as hemiparesis, severely limited movements, memory loss, slowed or slurred speech. Continuing the clinical features, balance problem, weakness in the leg or arm or one side of the body. It all depends upon the lesion of the brain, where exactly the stroke has happened. Off and on numbness, unusual physical sensation, sensitivity to cold sensation, difficulty in remembering words, dependency, little role in activities of daily life, and depression. Now coming to the most important physiotherapy and rehabilitation program and options, what we have. Positioning is very important when the stroke happens. The most important thing is positioning to prevent the contractures. When the stroke happens, start the physical rehabilitation from day one. Cryotherapy, breathing exercises to maintain the venous flow, soft tissue manipulation, electrotherapy, stretching, passive movements, PNF, bridging, core stability, weight bearing, gait training, strength training with therapists, chair aerobics, modified yoga, and home exercise programming. These are some of the major things what we have to do in physical rehabilitation. Now coming to the latest approaches, what are the latest approaches in stroke rehabilitation? What I mean, the updated approach. The neuron system, neuroplasticity, mental move, matrix therapy, robotic arms, V-games, mirror therapy, constraint-induced movement therapy, group therapy, aerobic modified, and core stability. Now coming to the mirror neuron system. If I am holding a mobile phone in my hand, I am just taking it from the table. It's action execution. When I am taking a mobile phone in my hand, my motor and premotor cortex gets activated. Similarly, if any other person is taking this mobile phone and I'm observing him, this action observation, similarly, against same motor and premotor cortex gets activated. Now, if I am imagining I'm taking a mobile phone in my hand, same motor and premotor cortex gets activated. And these things, action execution, action observation, and motor imagery forms a mirror neuron system. When a stroke happens, one thing is not possible, that is action execution is gone. But still two things are there, action observation and motor imagery. So taking these two as a factor thing, we can do much advance in stroke rehabilitation. Now coming to the science of neuroplasticity. Neuroplasticity is defined as the brain's ability to reorganize itself by forming new neuronal and synaptic interconnections and thereby develop and adapt to new functions and roles as a result of the effect of the learning and experience throughout the life. See, neuroplasticity, suppose my right side parietal lobe is damaged due to stroke. Now the pathways are gone. But our brain is having the capability to regenerate the synaptic pathways interconnections. So when we are doing relearning programs, these new neuronal pathways are formed. That's why after stroke rehabilitation, after a proper rehabilitation program, you can perform the patients can perform movements and all. Coming to the advancement in the technology, mental move therapy is considered to be a very important in the field of brain relearning process as well as neuroplasticity program. This is a device similar to the stimulation, but what happens when electrodes are placed, suppose my right arm is flaccid, 2 electrodes are placed, they are checking the innervation first, then they ask me to perform an mental imaginary, the patient, like you tell him that a person is coming, give him a task, like ask him that your friend is coming after 20 years or 30 years, he is coming to see you and you are going to wave your hand. And when he reaches to that threshold frequency, you just record it and save it in the device. Now, he does not have to actually execute the action. His hand will be down, everything is recorded in the machine, start the machine and ask him to perform a task. Tell him that his friend is coming and he is going to wave, but not in actual, his hand is in a relaxed position. So what happens? You tell him that your friend is coming, perform the task. He is practicing in mind, he is just imagining that his friend is coming, he is lifting the hand. As he reaches to that threshold, his efferent fibers from the brain goes to the machine, tells him that he has performed the task. The machine gives the stimulus to the hand and the hand moves like this. So the principle behind this working is based on the mental practice of motor skill, also called as idiomotor training. A purposeful action or a motor skill is mentally practiced by the subject without actually executing the movement. As I told you about the mental imagery can play a role in the motor learning, and the improvement of the motor performance is no longer questions because some research are going on and we are getting a very, very wonderful result in it. These are the loop, as I told you about the performance of the movement and how it goes. I'm showing you the movement, sensory, CNS and muscles. This is the loop created, control loop of the voluntary motor scheme. So what happens? Efferent fibers goes directly to the machine and it gives stimulus to the muscle and the movements are done. Now mode of operation. Patient to be relaxed. Mental move measures EMG at relaxation. Patient imagines a perfect full movement without really executing it. EMG in the muscle increases. Mental move measures the EMG in the muscle. Stimulus threshold is reached. Muscle contraction resulting in desired movement and feedback to the CNS. So it's a feedback as well as relearning process machine, which is actually purposeful, where the brain is totally involved in the action and the person is really re-educating the brain again and again. And by this, every time if we are performing this movement, our neuroplasticity increases. New pathways are formed and it will boost up the pathway formation. Aims of the mental move therapy is relearning, then reducing spasticity, recruiting secondary impairments, for example shoulder pain, which is very common in case of hemiplegic shoulder, we call it in stroke, to improve concentration and motivation, to increase the standard of living for the patient and their family, and helps to resume the work. Some of the indications and contraindications include the contraindications, mostly the heart pacemakers, pregnancy and dementia, and indications of mental move therapy, paralysis of the extremities, then brain tumors, brain damage, multiple sclerosis, in early childhood brain damage, and incomplete spinal cord injuries or Brown skull syndrome. Now coming to the very important topic, the matrix rhythm therapy. Matrix rhythm therapy is a device, modern device, which has been invented by a German scientist known, his name is Dr. Rundle. His concept is that every living cell is vibrating at a certain hertz. And when this vibration starts from the birth to the death, but when a cell stops vibrating, that means a disease has occurred at that very particular point, where that very particular site. As if we go beyond into the chemistry, Dr. de Broglie's equation says that every particle in the universe is in a rhythm. The main aim of matrix rhythm therapy is to synchronize with the body physiologically and give this exactly same hertz which has been lost in the cell, give externally the same rhythm, synchronize with the physiology of the body, and thus perform a micro vibrating oscillatory movements within the cell, which in turn increases the osmosis and as well as increases the circulation, and thus enhances and gives the oxygen to the tissue, to the cell, thereby the healthy cells are regenerated and thereby the recovery of the pathology which is over there. As I told you, a German surgeon by the name of Dr. Rundle spent many years in conducting scientific studies and found that all living cells vibrate at a specific rate. This vibration provides the delivery mechanism to supply the body cell with the optimum environment needed to support the demand on our body. The vibration allows our body to maintain a living level of health. And he says that it is from rigor mortis to life. It's a reincarnation of the cell, cellular elements, and the concept is that a cell is the basic thing, which is, if a cell is healthy, the tissue becomes healthy. If the tissue becomes healthy, the organ becomes healthy. If the organ becomes healthy, naturally the health will prevail in the body. Some of the matrix results: kyphotic children to straight line, straight sitting. See, scoliotic curve, now straight sitting. It's after the matrix session. See the slide, contracture over here, tightness, and see after matrix session. And now coming to robotic arm. Robotic arm, this study has been done in University of Boston, and in this it is also working on telepathical approach, in which if my hand is flaccid, an exoskeleton is attached with it, and my mental practice helps in performance of the moment. So when we talk about robotic arm, stroke patients get helping hand from telepathic robotic arm, which can respond to your thoughts. That means telepathically you are performing some movement, and it helps you in executing, helping you to perform the exact movements. And even if you have a slight power in the grade 1 or grade 2 within the hand, arm, and this is actually attached to the palm, to the hand, up to the elbow, and you can perform the movement. If you have a slight contraction, a slight minimum power in the muscle, it helps to provide the resistance and thereby giving the strengthening as well. And this study was done led by Rice University and the University of Boston, has led to an exoskeleton which covers the arm and fingertips to elbow and can help perform simple tasks as well, gently assisting and sometimes resisting movement to build the strength and accuracy, and thereby, and it's a relearning process, and again it reaches to the same mirror neuron system: action execution, action observation, and mental imagery. Now coming to the, as you know, giving a person same day, same curd rice will not help. If I get a curd rice every day, I'll be fed up with it. I will tell I need some change. So, these stroke patients, strokies, go to the clinic, rehabilitation clinic every day, receive the same exercise, and they get bored of. Give them a task-oriented something, which is a purposeful moments. There is a kind of a game in the market known as V games. V games are now displayed within the clinic, and the patient is sitting, and it's a sensor-oriented game. Suppose a racket in his hand and ball is inside the television, and you are doing some movement, the ball is moving. That means he is going to perform the movement without actually hitting the ball, just sensor-oriented. So it's helping him to do the task, and we are getting our movements. Do any, like for example, a ball is there, football, and he's just lifting his leg, the ball is moving. So we are getting some purposeful actions in that. This weekend, active video games may bring some fun into stroke recovery, helping patients again lost strength and motor skills in the process. It's a lot easier to stick with exercises that are fun to do than with those that feel like a chore. That's especially true for victims of stroke going through rehabilitation. That's why the use of video games to aid stroke rehabilitation has become a major focus of research. And still, the research are going on. They may come up with some latest things in it. There's a growing evidence that virtual reality games system like the V games can help stroke victims regain some arm function and even improve balance and visual impairments. The V has proven to be very popular within the rehabilitation. Now coming to the mirror box therapy. Mirror box therapy is also, if you go back, what I said earlier, mirror neuron system. It's also same thing. Now, what's there? In the sagittal plane, a box is kept. A black box with a mirror on the unaffected side, facing the mirror, facing the unaffected side. Now, inside the box, I will keep my weak hand. Okay, weak hand inside the box. And the box is covered, only the hand is inside. Outside the box, only I can see the mirror. I keep my good hand over here. It's in mid-sagittal plane. Okay, so I am keeping my hand here. I am doing some movements, and in the mirror I am watching. And when the reflection of the left goes into the, for example, my right is affected and right side hand is inside the box. Mirror is reflecting here. I am watching my left hand, and in the mirror it reflects my right hand, isn't it? So what we do? I perform my left hand movements like this, and my brain is telling it's going in the right hand because the picture in the sagittal is coming with the right hand. So I'm performing the movements, and thereby the new pathways, relearning, going on. And this is a wonderful experience. There are research papers on it, and it's doing wonders. Now coming to the constraint-induced movement therapy, it's developed by occupational therapists. Forces the use of the affected side by restraining the unaffected side. With CI therapy, the therapist constrains the survivor's unaffected arm in a sling. The survivor then uses his or her left arm repeatedly and intensely for 2 weeks. For example, my left hand is hemiplegic, okay, and my right hand is good. So I have to constrain my right hand, use ability of my left hand. So what I am doing, first day I cannot lift. I am not using my right hand, I am not using my good hand, only the weak hand. First day I cannot lift, second day a little bit, third day a little bit, fourth day I can lift. Or in 2 weeks, because we have to give in 2 weeks intensive training of this, and you can, because there is no chance for me, I have to use my weak hand. So it's constraining the good hand and using the weak hand. Now coming to the group therapy. This is a very good example of stroke rehabilitation. You know, there are very much geriatric cases as well as young cases. A group therapy, geriatric, pediatric, as well as the youngsters who are suffering from stroke. Now, if we are having a concept of building up a good rehabilitation center, which you can provide group therapy, and you can hire many physios for that. Group therapy, like, we can divide it into advanced, intermediate, and early. You are getting the cases, evaluate them, differentiate them into 3 groups. Advanced means those who are having hemiplegia but they are using the sticks to walk, tonkards or tripod stands, or they are walking with some deficit. That means advanced. Keep them aside, group them in one. Wheelchair bound, group them into early. Intermediate. And early are those who are still bedridden. So start giving advanced a good training. Give them a different variety program. As you are doing the group therapy, watch them carefully, have their caretakers with them, give them the lifting techniques, teach them everything so that they can help at home as well. Plus, the physios, those who are around, ask them to watch out carefully. Everybody is performing the activity every day. Give them modified aerobics, give them one-day aerobics, purposeful moments, give them, teach them occupational therapy, teach them every detail, every day, like give them variety programs, station exercises, one station for hand, one station for leg, one station for core, one station for cycling, and like a play-by method. It's the best method, and one day keep them to go with arrange a visit to a park, visit to a shopping mall, visit to a zoo. Like that, make them a part and parcel of the community. Ask them that you belong to our community, and just make them with the community. As they progress, discharge them slowly. If you feel that they are, take their assessment every weekly, take their assessment, prognosis, and leave them. Then wheelchair bound, modify everything in according to their things. Then when they leave the wheelchair, they are in standing with the help of support. Shift them to the advanced group. Early, those who are bedridden, give them the rehabilitation protocol, take the assessment regularly, take them when they show any progression, take them to the wheelchair group. After they get ability to stand with the support, shift it to them advanced, and simultaneously discharge them and provide the programs. When you talk about this approach, usually involves a few number of physiotherapists and their assistant along with the caretakers of the stroke patients. A detailed assessment is taken of the patients with stroke. With respect to the outcome of the assessment, the patient are categorized according to the level of impairment in the following groups: early, recently discharged, intermediate, mostly wheelchair bound, advanced, ability to stand with walk and walk with support. Exercise therapy regime should be designed after reviewing the assessment. Now, as I told you, aerobics can be performed very finely, but for them we need to modify the aerobic exercises. Aerobic exercise refers to the physical activity that requires the body to use oxygen to generate energy. After stroke, it's common to experience continued difficulty in mobility, for example in walking. It is important to continue exercise despite these challenges to avoid a vicious cycle. So what exactly I mean, aerobic exercise needs to be modified for these stroke patients. Core stability is very important for the mobility of the stroke patients. We can do core stability in lying, in sitting, in Bobart wall, in every moment of stroke patient's life. They need to have a strong core to stand, to stay balanced, sitting, balanced, standing and all. Preventing another stroke. After stroke, survivors tend to focus on rehabilitation and recovery. but preventing another stroke or recurrent stroke is also a key concern. Of 7,95,000 Americans who have a stroke each year, 5 to 14 persons will have a second stroke within 1 year. Within 5 years, stroke will reoccur in 24% of women and 42% of men. Percentage of recurrence after first stroke within 30 days, 3 to 10%. Within 1 year, 15 to 14%. Within 5 years, 25 to 40%. Your lifestyle choices, everyone has some stroke risk, but there are two types of stroke risk factors. One type your client cannot control, the other he or she can control. Advise your patient as follows. Monitor your blood pressure, which is in your hand. If it is high, make sure it is treated with proper medication. Find out if you have an arterial fibrillation and irregular heartbeat, which allows blood to pool in the heart and causes blood clots. Quit smoking. Quit smoking. Limit alcohol. Check your cholesterol levels and make sure bad cholesterol is controlled. Manage your diabetes. Exercise often, very often exercise. Eat food low in sodium, salt, and saturated or trans fat. Monitor circulation problems with the help of your doctor. And this is really going to boost you, because this all what I told is in your hands. So modify your lifestyle, do your best, and you will be very safe from stroke. Have a stroke-free life. Physiotherapists, a ray of hope we are for life after stroke. Fellowship certificate in WSH approach towards stroke rehabilitation prevention. London Academy is conducting this hands-on program. If you are interested, you can contact me on my email, which is warishaqani@gmail.com, or you can directly approach to the Lash's website and request them for the same. And we thank you for your patience, and thank you so much for having patience to listen to me, and thank you very much.